Hello, everyone. I'm your host here again. My name is Sachima, and I hope you're having a great day today, a great week. The last time we introduced depression as a mental health diagnosis, we talked about depression, what is depression, what are the symptoms of depression, how one can present so we can formulate a diagnosis. That's what we talked about last time. So today we're going to talk about the differential diagnosis of depression and some of the somehow touch the treatment of depression. So first, we're going to look at the mental status examination of someone who has depression. We'll start with a general description. We have what is called psychomotor retardation, which is the most common symptom. Here, the person is going to have like a stooped posture. The person looks downcast, sad. Um, there's sometimes what we call psychomotor agitation. This is seen especially in the older people. Here, you see them pulling out their hair, pulling out their hands. You see their hands wriggling. The next thing we talk about is mood affects and feelings. Depression is the key symptom. So here there's social withdrawal. The person is withdrawn. Speech, patient has decreased rates of speech, decreased volume, may even be whispering, and may respond to questions with monosyllables or delayed responses. You can wait for about 2 to 3 minutes, before the person can reply or respond to a question. You also have perceptual disturbances. Depressed people that have delusions or hallucinations have depressive episodes with psychotic features. We talked about this earlier in the first video. So delusions or hallucinations that are consistent with a depressed mood is called mood congruent. For example, when a person is feeling guilty, worthlessness, poverty, failure, persecution. You also have mood incongruent delusions or hallucinations. This is when the delusions or hallucinations is not congruent with the depression, like grandiose themes, like a person having exaggerated power, exaggerated knowledge, you think is God. We talk about thoughts. Depressed people have a negative view of the world and of themselves. Their thought contents include things about loss, guilt, suicide, death. The thought disorder include thought blocking and poverty of content. So thought blocking and poverty of content. We look at the memory. 50 to 75% of depressed people have cognitive impairment called depressive pseudo dementia. Now, these people complain of forgetfulness. They can't remember a lot of things. Impulse control. 10 to 15% of depressed patients die by suicide, and about two-thirds of people that have depression think about suicide. They have suicidal thoughts. So we need to look out for that. Now, for the differential diagnosis, there are numerous. The first one we'll talk about is grief reaction or bereavement. Depressive symptoms may be transiently present in a person experiencing normal grief. You can experience normal grief after the loss of a loved one. Usually, someone in your family died, a spouse, a child. Symptoms are consistent with depression might include inappropriate guilt regarding actions surrounding the death of that loved one. So you can also have persistent thoughts of death. The survivor's feeling that he or she would be better off dead, or should have been the one to die, or should have died with the person that died. All these are considered a normal part of the grief reaction. There is also a preoccupation with worthlessness, and there's also marked psychomotor retardation. The patient is stooped, sad, prolonged, and marked functional impairment. Sometimes you can have hallucinations. People can briefly hear the voice of or see the deceased person, but this is, considered within the normal scope of grief reaction or bereavement. Another differential diagnosis that we're going to talk about is persistent depressive disorder also known as dysthymia. Here, a person has a depressed mood for most of the day for at least 2 years. Get that, 2 years. So if the patient is a child or a teen, the symptoms only need to be happening for at least 1 year. That's for a teen or a child. So like I said in the first video that I talked about, the past video I talked about dysthymia. People that have dysthymia, get it, can function, but it can't function to their fullest. So treatment mostly is usually psychotherapy or talk therapy, and least likely with medications. Another differential we're going to talk about today is adjustment disorder with depressed mood. Now, this is a depressed mood with an identified precipitating event or a big life change happen when you move from city to city, or something big happens in your life. This usually does not require medication, and it resolves with resolution of the acute stressor. Another differential diagnosis is premenstrual dysphoric disorder, also known as PMDD. This is a health problem that is similar to premenstrual syndrome, also known as PMS, but this is more serious. PMDD causes severe irritability, depression, or anxiety. It usually happens a week or two before the menstrual period starts in females. The symptoms usually goes away 2 or 3 days after the menstrual period. So within that time, you see females with irritability, anger, depressed mood, and all that. Another differential is organic and medical causes like hypothyroidism, multiple sclerosis, vitamin B12 deficiency, Addison's disease, and medications like antihypertensives, some analgesics, some antibacterial, and so on. They can cause depression. So a good history should be done in order to make a correct diagnosis. Other mental disorders like substance-related disorders, psychotic disorders like schizophrenia, eating disorder, and anxiety disorder are all commonly associated with depressive symptoms. So we need to, be aware of that. Now we'll go to treatment modalities. Now the goal of treatment of depression is to ensure safety. Now we use medications like antidepressants. Examples are like the selective serotonin reuptake inhibitors, also called SSRIs. Examples of them include fluoxetine, paroxetine, sertraline. We also have selective norepinephrine reuptake inhibitors, SNRIs. Examples of venlafaxine, duloxetine. Other medications include buspirone, bupropion, mirtazapine, trazodone, and so on and so forth. We'll go in depth into medications in a later video of psychopharmacology, okay? The next treatment modality is psychotherapy, including cognitive behavioral therapy, interpersonal therapy, and family therapy. The third is transcranial magnetic stimulation, TMS, which uses magnetic energy to stimulate nerve cells in the brain. It's scary, huh? Yes. It is indicated in people who have tried medications at an effective dose and an effective duration, and it doesn't work. It is non-convulsive, there's no need for anesthesia, and it has a safe side effect profile, unlike ECT, which causes some convulsions and use anesthesia. This can be done on an outpatient daily for about 4 to 6 weeks, and is not usually done in people with metallic objects in the head. Another treatment modality is phototherapy. We talked about this in the first video. We talked about seasonal affective disorder, SAD. Now, folks, depression is real, okay? So please, if you notice that you or someone you know is having symptoms, the symptoms I talked about of depression, go and see your doctor for proper diagnosis and proper treatment, okay? So that is my advice to you. Don't take this video literally, just go and see your doctor. The next time we'll talk about anxiety disorders. We'll talk in scope about that. Subscribe at my YouTube channel. Feel free to email me at letstalkpsychiatry@gmail.com. Send your questions, your concerns. Until next time, stay stigma free, and let's be aware of mental illness. Okay? Bye for now. Take care.